Welcome to Journal Club, November 25th, 2019. We're just sort of getting back into the swing of things, and does anyone have any interesting cases they want to talk about?
That'll start us off. So this was a case that started off by me speaking with the paramedic, and they're out in the field. They called me to tell me that they had a elderly female patient, shortness of breath, from home. But unfortunately, as is often the case in the field, it's a patient that's pretty old and has all the history in the world. You know, your typical diabetes, hypertension, COPD, still smoking, but also multiple MIs and CHF. So, as they're giving me the presentation, even they're unsure as to which way this one's going, whether it's straight COPD, straight CHF, or a mix of the two. Of the evidence that they gave, the patient had been on the hypoxic side, really wasn't moving air much at all. What they could hear was just some mild expiratory wheezing, but otherwise a pretty silent chest. But of course, they also had pitting peripheral edema, and they were hypertensive, which some people will say, oh, well, that leans towards failure. But in somebody that's that significantly short of breath, as we've all seen, you can be hypertensive just simply for being that short of breath and not being able to move any air. So they had already started the patient on some duo nebs, but they gave it through the CPAP. So even though CPAP can be great for COPD and asthma, if they're thinking that this is a little bit of both, that also will help out with your failure. So unfortunately, I was stuck in the ER, so I wasn't able to lend them a hand or lend them my ultrasound to help differentiate this. So they continued with the duo nebs. They gave a little bit of mag, 2 grams, and some steroids. And they were debating on whether or not to give some nitrates. Thankfully, they were relatively close to us, so by the time they got to us, they had gotten their meds on board, had not given any nitrates yet. And literally, as soon as they walked through the door, we just walk over with the ultrasound, put the ultrasound on the chest, and there would be lines everywhere. So at that point, first off, they had improved the patient. They were no longer a silent chest. At this point, you could hear bronchi all over the place, wheezes, you can even call them wet rails, but the combination of the ultrasound and then later on confirmed with the x-ray showing vascular congestion throughout, we continued obviously the BiPAP, finished off their duo nebs, and then put the patient on a nitroglycerin drip. Did incredibly well. And, admitted just because they still needed some additional diuresis, and they weren't going to make it out in one day, but still, that differentiation can be very difficult to work on. That's why it was really nice in Atlantic City last week when we had the class showing the paramedics how to use the ultrasound and how quickly we can use it to help us differentiate between those two. Because you can look at end tidal, you can look for your shark finning, for your bronchoconstriction all you want, but if it's a mixed picture, you can't just ignore the other end of it. And thankfully, we were able to get all that done in a short period of time for the benefit of the patient.
Yeah, so we're very big proponents of pre-hospital ultrasound, and the more you get tools into people's hands that can actually make a difference, it helps. We were showing down in Atlantic City how fast you can see the lung, how fast you can look in the belly, how fast you can find these very simple findings. And, if you just use the ultrasound on your patients who are not actually in super distress, but just looking at them with a regular asthma exacerbation, with a regular COPD exacerbation, and then the ones where it's a CHF exacerbation, you see them very quickly, and you have a quick, okay, which way do I go with this patient? Yeah. The undifferentiated shortness of breath is one of the big ones that I like to use ultrasound for. The other two is cardiac arrest and trauma.
The hypotensive patient.
Yeah, the hypotensive, so it's the rush exam. Why are they hypotensive? Are they bleeding in their belly? Do they have enough volume in their system? Things along those lines. And then once in a while, you can use it to start an IV line, but if it's that bad, it's like, and they're not that sick, they can wait till they get to the hospital. But it's for those big ones. Why are they hypertensive? Why are they shortness of breath? Is their heart beating? Because a lot of times in cardiac arrest, you feel for a pulse. You may not feel a pulse, but a lot of times I found that, the heart is having good squeeze, but we just don't feel the pulse. So starting a pressor, doing something along those lines will actually bring the pressure up to the point where you can actually feel it. So, that's a good case. Anyone else have, you want to talk about his case or something similar or your own case?
I can do it. Any case.
All right, so this was a few weeks ago now, I think. It was a 71-year-old female who came into the ED complaining basically of abdominal pain. I had actually gotten a call from another provider who stated that the patient had recently underwent a DNC approximately like 2 days ago. Or 2 days prior to the presentation, and she was concerned because the patient was having some pain and just had a decreased appetite, wasn't really recovering as well as or as quickly as she thought that she should be. So the patient was 71 years old. She came in, she had a history of hypertension and high cholesterol and the recent DNC, and was basically just saying her stomach hurt. She hadn't really been able to eat anything in the last, or since the procedure. She had a little bit of a fever. When we initially thought and spoke to the provider who referred her to the ED, the concern was that she possibly had some sort of infection, like endometritis or something like that, just from the procedure itself, or that she didn't tolerate the anesthesia well. And so she just thought maybe come in, hydrate her, see if she can get some antibiotics versus does she need to stay in and get IV antibiotics. When she got to us, we found her to be kind of hypotensive. Hypotensive. She was 80s over 60s. She was tachycardic to 130s, and she had a fever of 102.5, and was kind of tachypnic, but nothing crazy. So we asked her, what have you tried to do? She's like, I just haven't been able to do anything. The pain has been so bad. So on her exam, she was kind of lethargic, wasn't really, or slow to answering questions, didn't really complain of any shortness of breath, didn't look like she was in respiratory distress. She was hot to touch. As far as her belly exam, it was distended. She had diffuse abdominal tenderness, and she had bowel sounds that were present. So we got a stat, upright chest x-ray, got labs, started fluids, actually went ahead and started antibiotics as well. And I told radiology, call me when you get to bedside. I want to take a look at the x-ray. In the meantime, I went ahead and looked through the procedure reports. So this patient, they had a really difficult, so she had cervical stenosis. So they had a difficult time actually performing the DNC and had to use some different instruments to dilate the cervix so that they could actually perform the DNC itself. So I was concerned that possibly they perforated something. And as soon as the tech got there, we shot the x-ray. She actually had pneumoperitoneum, so she had free air not only under the right, but also under the left diaphragm. So at this point, we had already notified GYN, but I actually called surgery, general surgery as well. So we did a CT. Once we got her fluids and everything in, she stabilized. We got her some pain medications to the point where we could just go ahead and go straight to CT. Once we got her to CT, she actually ended up having not only she had a uterine perforation, but because of the amount of free air, there was concern, and she had a fluid collection there. They did a kind of tandem surgery, went with both GYN as well as general surgery, and she ended up having also a small bowel perforation as well. So it was pretty interesting.
Yeah, that's a lot.
Right.
Yeah. So the big things that I was thinking about when you were telling me when you were presenting the case was 71-year-old. Why is she getting a DNC?
Right. So she had postmenopausal bleeding.
Yeah. So you're worried about cancer. You're
Right.
worried about all these things. On top of that, post DNC, so she's post-surgical procedure, increased risk for PE, things like that. And then on top of that, now this diffuse belly pain.
Right.
It's just like one bad red flag after another.
Right. So she was a patient actually that we did. I grabbed the ultrasound pretty quickly, and although I couldn't tell that she had free air on the ultrasound, it was difficult to view the abdominal contents compared to what you would expect. And when performing ultrasounds, anytime you have air, you have a lot of, or your visualization is decreased. So I, again, increased my suspicion that there was something bad going on in the belly as well. But heart, I mean, she was, other than being slightly hyperdynamic, nothing really crazy. I didn't see any right-sided issues that concerned me for a PE, but she was hypotensive and she was tachycardic and she was slightly tachypnic. She did recently have a surgery, though not really invasive, but she was been laying in bed recently. So could she have a PE? Absolutely. But again, another plug for using ultrasound.
That's one thing that you mentioned that's very important, that ultrasound doesn't see through air. So while you're doing your kind of EFAS exam on this post-surgical patient, I don't even know if you would be, were you able to get your views? Just
not really. It was
she was in so much pain
right.
as well.
Exactly.
So you don't want to be pushing onto a rib while she's screaming in pain.
Right.
You can give her fentanyl because it really doesn't affect the blood pressure that much.
Right.
But at the same time, you have to consider: am I going to give this woman who's hypertensive, do I give her saline to kind of help with the blood pressure, or does she need blood?
Right.
So you know that she's post-surgical. For me, the difference is going to be, does she have tail conjunctiva? Does she have, you look at underneath her tongue, things like that. Which way am I going with this?
Right.
And then as soon as you get to the emergency room, this is going to probably be a code sepsis. She's hypotensive, she's febrile, she has abdominal pain, something's going on. But then you have to kind of think about, what antibiotic am I going to use? Am I going to do very broad spectrum, which I would have just gotten broad?
Right.
Or do you be more specific, Gen-Amp or something like that, dosing?
Right. So that was a discussion that we had. And I figured, I said, since the patient was so sick, and I wasn't really that impressed that this would be an endometritis. She looked just more sick than an endometritis would be. I said, let's just stay broad and we'll go with it. We'll cover intra-abdominal as well. And so that's what we did. They actually continued the course that we started in the ED. But I thought one of the other interesting parts about the case was that this patient didn't call the provider. This was the reason that this patient actually presented to us was because it was a kind of an operations thing. She had this at the same day procedure. She went home the exact same day. I think it was on like a Friday, maybe was the procedure. The nurse from the same day procedure or same day center called just in a regular checkup saying, hey, how are you feeling? And she was concerned with the patient and how she was talking. So then the nurse called the surgeon or the GYN doc, and it was that call by the nurse and the system that it actually just kind of worked out to the favor of the patient, and that we got this patient. I think another the patient was very stoic. You pressed her on her belly and you could tell she was in pain, but she really didn't. Oh, it's not that bad. She really didn't want to come to the hospital, but very obviously sick when she got here. So I think would have stayed at home and had a really bad outcome.
Yeah, and that's the other thing. So we get the case all the time where, you know, maybe you do a wellness check, or, you know, a family calls and you say, hey, you know, grandma's not answering the phone. And then you show up and, you know, maybe they're refusing your care, and sometimes you just have to be a little more persistent. And, you know, because people don't want to go to the hospital. And sometimes they really do need to go to the hospital, and kind of pulling in resources like calling family, calling like a loved one or like a cousin or someone who, you know, with the patient's permission, you know, to kind of help you get that person out. You know, sometimes we run into trouble where, you know, maybe there's a power of attorney or there's a healthcare proxy, and, you know, if the person's not altered, you know, we're not in the business of kidnapping. So we don't want to, this always comes up, but I find that, you know, if you're really and truly trying to act in the best interest of the patient, and even if the patient doesn't want to go, you're like, listen, you know, everyone here, you know, we really don't think that you're doing well. You know, if your intention is to do good and help the patient, it usually turns out okay. But sometimes you have to involve more people. Sometimes you may have to involve the police. Sometimes you have to involve a bunch of people. So it usually comes up every couple months, this exact case where someone is sick and doesn't want to go to the hospital. Everyone else is saying they're sick, they need to go to the hospital. And then now you have to balance between, patient autonomy, patient, what's beneficence, and what's the third word? I don't know.
Non-beneficence.
It's true. Like if you really didn't want to go, you understand. So where does that line? And the problem is the line is very gray. It's not a clear cut line. Anyone else have anything on that topic?
No, nothing.
You want to switch over to the articles? All right. Let's switch over to the articles.
So, anybody have any articles they're dying to talk about? Because I've got one. So I am going to take an article from Resuscitation, which is the European Resuscitation Council's journal. The article is titled "Epinephrine for Out-of-Hospital Cardiac Arrest: A Systemic Review and Meta-Analysis of Randomized Controlled Trials." This was done by Vargas et al. He is out of the Department of Neurosciences, Reproductive and Odontostomatological Sciences, University of Naples, Italy. So, European study. But this was actually, I'm excited to talk about this one because it's a meta-analysis that is pretty important, and it can refute some other papers we've talked about earlier, and I think this is an important paper. So what they did, they looked at a whole bunch of randomized controlled trials, and this was interesting how they actually selected this, and I think it was pretty smart. They looked at only randomized controlled trials unless there wasn't enough randomized controlled trials on their subject to create a robust sort of conclusion, and then they looked at some observational studies. And what they found is a few interesting things. So overall, it's out-of-hospital cardiac arrest, survival to hospital discharge is 8 to 10%. So you actually have a better chance of surviving a thoracotomy than out-of-hospital cardiac arrest, just in general. But they looked at 15 randomized controlled trials representing 20,716 out-of-hospital cardiac arrest adult patients. And they compared a few things. So they compared epinephrine compared to placebo or no drugs, survival to discharge, ROSC, and survival to hospital admission, and found that using epinephrine was better than either not using any drugs at all or using a placebo under all those cases. So survival to hospital discharge, ROSC, and survival to hospital admission. They found that with standard dose epinephrine, there was no difference in favorable neurological outcome. And then they also looked at this high dose epinephrine, and they found that they had higher rates of ROSC versus standard dose epinephrine. And they also found that they had an increased survival to hospital admission using a high dose epinephrine, which, due to the fact that this was based on multiple randomized controlled trials, the actual dosages for that varied. But the important thing is what they're trying to show is that even the dosage of epinephrine is maybe not necessarily something that we have a good handle on. But they found that with high dose epinephrine that there was no difference in neurological outcomes after cardiac arrest. So a few things that kind of went over, obviously, with the fact that this is a meta-analysis. They had a lot of statistical discussions about the statistics that they used and all that. And they talked specifically about the Paramedic 2 trial, which we actually discussed earlier. And what they basically found was that the Paramedic 2 trial did show that epinephrine was associated with a slight improvement in 30-day survival. But no, there was actually more survivals in the epinephrine group that had neurologic impairment, which is what we had talked about earlier with unfavorable neurological outcomes. So, essentially what they looked at was that, that was basically it, oddly enough. That was pretty much the conclusions of this meta-analysis. But basically what they talked about a lot in this was the fact that there are many factors that come into play after a hospital admission that may actually confound the fact that your survival to discharge and unfavorable or neurological outcomes were unchanged with the use of epinephrine. But their recommendations based upon this is basically to use epinephrine because we can then address those confounders that may be leading to no difference at the backside. But if we can get them into the hospital and all that, and then maybe further studies looking at other interventions such as optimization of respiratory functions and cardiac, sort of arrhythmias and all that. It was also interesting that this analysis looked at a fragility index for randomized controlled trials. And this is worth talking about because what they did is they essentially used some newer analysis or analytic methods to look at how robust are these randomized controls in general. And give that sort of weight, give weight in these meta-analysis to the higher quality randomized controlled trials. And what they found is that their results, with taking into account this fragility index of these randomized controlled trials, did show that there was some benefit to using epinephrine. And the high dose epinephrine, while it did show them favorable results in this meta-analysis, they're still saying that may not be ready for prime time. Like, probably more studies still need to be done on what is the optimal dose for epinephrine because this may show that we don't have that yet. So this is a great paper, and I think this actually, because it is a meta-analysis and because we can hang our hats on the results of these large deals, and it does look like they did some very smart stuff when it came to how they looked at all of this data and the studies that they did choose, and they had a large number of patients. I think this can and this should change practice.
Well, the whole thing, the reason why I chose this study was because last year they came out with an article that said epinephrine doesn't help. And everyone just like, wait, what? And this article kind of said, wait, let's slow it down. Like, it does help. We just don't know who it helps. And that's one of the big things. And I've been saying for a long time that one of the biggest problems that we have is identifying the cardiac arrest and trying to figure out is who is that patient that has a cardiac arrest? Is it the patient who's been in bed and died 8 hours ago? Because no amount of drugs, no amount of CPR or anything, I'm going to bring someone who's been dead for 8 hours. Versus someone who is talking to me and then goes down. Okay, now I have a better chance. And I think those are two very different patients. And unfortunately, most of the time, we don't know which patients those are. We already have very low numbers to work with. So then we kind of tease it out. Finding those separations is going to be difficult.
For me, this changes nothing. I still think epinephrine is a horrible drug. And the reason I say this is because, you're right. I think we've always known this. Epinephrine increases your chances of rust. It increases your survival to admission because you're pumping them with medication that's going to basically flush the heart, and then you stent their survival a little bit, right? So you're able to keep people alive because you're giving them pressors. That just makes intuitive sense. So, and we've always known that if you give epinephrine, you increase your rate of rust. The question is, at the end of the day, is there meaningful survival, right? Is there meaningful neurological outcome on patients that were flogging their heart and making them survive past the cardiac arrest initial stent that they had? So sure, we're increasing your rate of, your ROS. We're increasing you being able to get into the hospital, but you're not increasing your hospital to discharge. So those people are dying, right? So the same amount of people are dying, right? There's no increase of survival outside of the hospital to discharge. And there's the most important part, there's no change in neurological outcome. So if I can't change your neurological outcome and you're still in a vegetative state, if you're leaving in a vegetative state, or if you're leaving with walking out the hospital completely fine, and there's that mix in between, if that number doesn't change at all, then what's the benefit is the question.
So that's actually a really good question, and I think it's something that this paper did discuss and it did answer.
Right.
So the point is the Paramedic 2 trials showed actually worse neurological outcomes. So at that point, we can say like, wow, okay, so we're bringing people back, but we're not bringing people back neurologically intact. So what's the point? Essentially, all we're doing is increasing the number of years, maybe not necessarily the quality of years. And so you can argue that. But in this study, it directly addressed that Paramedic 2 trial, and it did say that, hey, listen, here's the deal. Using epinephrine is maybe not have any sort of improvements in survival to discharge or favorable neurologic outcome, but it didn't show any detriment. And so their thing is at that point, you don't know which patients you're going to help, but using epinephrine seems to be helpful to get people to the hospital, and now we just need to figure out how to get people out of the hospital with, better results. So in reality, I think that this does say that, because I understand you can say like, oh, well, if there was no change, then what's the point in doing it? But their point was there was some change in getting people there, and now we just need to have some change in getting people out, with better outcomes. And our job is the front side. Our job is to get people to the hospital alive.
But no matter if they got epinephrine or they didn't, the outcome has ultimately been the same, right? So this again tells us that we really don't know what we're doing in cardiac arrest at the end of the day, right? We're still looking for that magical drug, and I don't think epinephrine is it. And I think you're right. We still have to continue, with what we feel that we can do to, achieve ROS and give the patient, the ultimate chance of survival, because we don't know what patient has that stent, what patient has, maybe a peripheral infusion prehospitally until we get, point of care ultrasound, at least in the field. But, we want to give everyone the chance that we can. We know, epinephrine does increase your chance for ROS. But again, I think what Navin said, I think what we need to start looking at more importantly is not that every patient across the board should be getting epinephrine, is what patients actually will benefit from epinephrine and who can we resuscitate better with epinephrine. And let's say you have a narrow complex PA arrest, right? And like we said, we do point of care ultrasound. We see actually there's some contractility. Now we know that this patient is probably not perfusing well enough to actually sustain, at least a palpable pulse. Maybe that's the patient we start pressors on, And so again, and that patient's going to get an epinephrine drip or a levo drip, right? And so, again, there is a role, I agree with you, to play, but I think we do have to be somewhat strategic. And I think that we've now moved into a phase where there's almost like three branches. There's going to be a systole phase where basically most shops across the nation are doing nothing for it. Well, not most, but a good majority are. And especially with epinephrine shortages. And then you have some that are patients in like a ventricular dysrhythmia that they're saying don't get epinephrine, maybe we should do beta blockers. And then there's that middle ground where they have kind of a PEA or pseudo-ND kind of rhythm where they're saying that's the patient we do epinephrine on. So I think there's more to come. And every year when we go to our conferences at MSP, we see more and more literature and more research being done on epinephrine and other medications to adjunct cardiac arrest. And I think that's kind of where we're headed.
And that would be a really interesting study. I'd like to see that in the future as far as let's take a look at maybe doing a subgroup analysis of trying to look at various interventions by, the arrhythmias that you find during the code. That would be kind of cool.
We just have to collect that data.
A good, robust data, because we have a lot of, and I guess that's the other thing that kind of frustrates me is we have a ton of low quality studies. And what we need is a few large, high quality studies to really kind of nail down this question that's been eluding us for 20 years.
Oh, more than.
Mm-hmm.
And I do have an article. I thought I posted it for this week, but I'll post it for next week. On like how do you identify the person with no chance of survival? Where's that line? Because especially as a new provider, especially in EMS, like I remember being a paramedic and coming to find a patient is like, do I start CPR on this person? Sometimes they're in bed and you're like, it's still a little warm, but they're just like have rigor. I'm like, I'm just gonna call it, but it's hard, the first couple times to make that decision. To be like, what, this is futile at this point. So there's a whole article on that. I think we reviewed a different article last week on that, but there's an article coming. I thought I put it for this week. I guess it will be for next week. But like we talk a lot about who has the best outcomes. So people who are witness arrest, initial rhythm, VTAC, VFib, end tidal, high. What are the other ones? Those are the ones that stand out in my mind. Early CPR, things like that. Those are the people with the best chance of ROS, and also good neurologic outcome. But not just getting the patient to the hospital, but getting them with the best chance. So, are you doing good CPR? Are you oxygenating the patient? We've talked about with the mechanical devices, where the person's on a mechanical device and they're trying to take it off. But as soon as they take it off, they go limp again because, the mechanical device, or even if you have pit crew CPR, where you're doing good CPR, you're perfusing the brain, and they're just like, wait a minute, what's going on? And then when you stop, the perfusion stops and you're down. So, all right, next article. Or someone else has something to say about this one?
Cool.
Sure. Yeah. So I looked at pre-hospital amputation and experimental comparison techniques. So it wasn't a meta-analysis, nothing complicated. They just simply compared 3 different saws. They compared the jiggly, the hacksaw, and the reciprocating saw. And the primary outcome was time. So they did it all on porcine legs, and the jiggly saw, you had to do a scalpel incision initially. The other 2, there was no incision. Came out to be around 30 seconds for the jiggly, around 6 seconds for the hacksaw, and around 3 for the reciprocating. And the cross-sectional area of the porcine legs was a lot smaller than human femur. Human femur is about 500% larger. So when they extrapolated that data, the times came out for human femur would be around 3 minutes for the jiggly, 30 seconds for the hacksaw, and 15 seconds for the reciprocating saw. Of note, the hacksaw and reciprocating saw are already on most fire trucks, so it's not like a specialized piece of equipment that you need to incorporate with the jiggly. And the other 2, you also don't need an initial incision. And the jiggly had 3 out of there was 27 total was the sample size. So you had a EMS doc or EM doc, medical student, and a medic doing these trials. And there was malfunctioning of the jiggly saw 3 out of the 9 times. So kind of as a thought provoker that maybe we don't need the jiggly saw in the field. Maybe the stuff that's on the trucks would already work, and it would be the quickest for amputations.
Yeah, so pre-hospital amputation is definitely one that comes up a lot. A lot of places say that they'll just get a surgeon from the hospital, but the problem is, how often does that happen? You know, how readily available is that? And the answer, it is not. You know, and then find someone who's willing to go out is another completely different story. You know, pre-hospital amputation is within our realm as EMS physicians, and within our training. The one thing that I know that Amandeep likes the reciprocating saw, but the problem is that you need a special blade. It's actually like a butcher blade.
You actually get it from your local butcher. So you actually can get it, because they actually use reciprocating saws as well. So you actually go to your butcher, you can actually get that. The problem is if you try to buy commercial, like the ones for like metal cutting and stuff, they actually have ink like on the actual blade because of the manufacturing company or whatever. And so when you're actually cutting through the actual bone, that ink is actually also being displaced and flayed into the patient's bone and marrow. So you have to be very mindful of that. So although most fire-based companies have a reciprocating saw, they don't have the actual blade that you need for cutting the femur. And I think that's a misnomer that most people are going to utilize that blade, but we have to be mindful of that. So when you go to a butcher shop, their blades are clean, like clean blades that have nothing on them. And so that's what you can effectively use on them.
Yeah, and the big thing with amputation that you have to think about is you want to salvage as much as possible. So you want to cut as low as possible, as far away as possible, because there's going to be a revision, and the revision is going to take more tissue away, more bone away, to kind of clean that area up. A lot of the times the Ghibli saw is the one that most people use because it doesn't require batteries. The problem is the handles break, the wires break, so you need more than one wire. The thing with the reciprocating saw is batteries fail, or the blades aren't sharp enough, things like that. And then if you're going through the tissue with the reciprocating saw, it causes a lot of tissue damage.
I mean, normally, ideally, I think what they're doing is they're probably going through the actual muscle and the soft tissue with the blade, and what they're testing is just the actual femur itself. And that's usually what you want to do. The Ghibli saw isn't meant to go through the soft tissue or the muscle; it's meant to go through just the bone. So ideally, what they're testing is this kind of the same thing. So the reciprocating saw, I think, is nice. It's a bulky thing, so a lot of times when we're using this to amputate, using it in entrapped patients, and the thing is that you're using it in a confined space. So you have a lot of limitations. I think it's ideal to have, when you're dealing with an entrapped patient, number one, you have to think of a couple things. Yeah, sometimes it may be time dependent, but I think a lot of times you have to look at what is ideal for your situation. So it may be a Ghibli saw because of the way you can actually just use your hand in this back and forth motion versus not being able to get a bulky reciprocating saw in the right position. Or you may be able to get a hacksaw because you might just be able to get a hand in, just one hand in, and not be able to kind of rotate around the femur, right? Because the Ghibli saw, you have to physically be able to get it around, completely around, right? So I think it's situation dependent on what can work. But it's nice to know what's faster, and I think that we intuitively can know that a reciprocating saw is going to buzz through something pretty quickly. A hacksaw is going to, just kind of saw through something pretty nice, depending on how dull or sharp it is. Again, just be very mindful. When you have a hacksaw or reciprocating blade, just make sure it's clean and it's actually, you can use it for actual like animals or humans, because that's what you want to make sure you don't get any of that ink or dye casted into the patient.
Yeah, should probably use a new blade.
Right. I mean, the Ghibli, the biggest thing is that one is only it breaks really fast, and as soon as you're done with it, it curls up like, if you guys never used it, it curls up so much that it's just, if you mess it up once, it's over.
Yeah, I find that with the Ghibli saw, if you just kind of use your weight to kind of seesaw it, it cuts through very quickly, like in a couple seconds. Like, how much did they estimate that it would take?
3 minutes.
I would cut through the femur a lot quicker than that.
And now remember, you're doing this in an ideal situation
Sure.
where you're in a cadaver lab and you're like right over this person, you just kind of put all the force you want into it. In any situation, you may not be able to put full force, right?
Maybe trapped.
And they're trapped, so it's just challenging. Everything's going to be a challenge based on that. Most surgeons, when they go to field, they bring their own reciprocating saw, but that reciprocating saw is battery operated, it's actually compact, and it's actually pretty good. It's got good, oscillation to it, very fine oscillation to it, right? And so it can actually buzz through pretty quickly. When you're talking about
but can you fit it in the right area?
right? I mean, ideally, you can. Those. When you talk about the surgical reciprocating saws, they're actually pretty small. They're like this big. That's it. When you talk about an actual commercial one that most fire rigs have, they're actually pretty, like usually about this long. Most of the reciprocating saws are this long, at least. And the ones that are battery operated the same. And you have to make sure that they're charged. And again, the blade itself, most blades are going to be long. They're at least 3 or 4 inches, sometimes longer. But again, it may be to your advantage that you have that because your reach might be that such that you may need to reach a little bit further. So I think it's all dependent on the scenario and the patient.
Which one would you go for? Your open space.
Open space, reciprocating
Open
saw.
safe. Space.
Reciprocating saw.
It's funny because when I took the amputation class, I felt the Ridley saw just gives me the nice flat cut. It was easier to cut with the saw, with the reciprocating saw. Like you're always there. You literally have to have the femur there because if not, you're jumping back and forth. You're not
Right.
cutting nicely, and there's bones going everywhere.
Using a reciprocating saw does take some practice.
That's true.
If you've never used one before, you will never make
Right.
a nice cut.
Once
Yeah.
people
Zero
It's like-
chance.
bounce on
Yeah.
the reciprocating saw, number one. And the reason why they're bouncing is because they're using the edge of the tip
Right.
to actually cut with, right? And when you do that, it becomes floppy and it actually makes these really jagged instrumentation. You're not really supposed to do that. What you're supposed to do is actually put the proximal portion of that, actually rest it on top where that portion is to actually sit on it and then actually oscillate into it. Again, it's all about the oscillation, right? So depending on how good of a reciprocating saw you have versus how cheap of one you have, let's just be honest, it depends on how coarse of a movement it'll have or how fine of a movement you have, right? So, and that's all dependent on what instrument you're using. So again, when you look at surgical reciprocating saws, very fine, very fast oscillations, and it goes through it pretty quickly.
I think it's just has a shorter control. Whatever.
Oscillation, right? Yeah.
So it's really comes down to what you're comfortable with and what your equipment is. So personally, I like the Giggly saw because of the fact that I don't have to maintain its battery. I can have multiple of them, but if I'm used to using the reciprocating saw, then you're going to use the reciprocating saw. And no one likes to hack stuff. Yeah. You have one more?
I did the case report. So it was pre-hospital lower into airway device placed in resulting hypopharyngeal perforation. Showed up in pre-hospital emergency care. The case report coming out of medical college Wisconsin. Published in 2019. It's a case of a 26-year-old female that was presented with a cardiac arrest, presumed opioid overdose, where EMS placed a king tube or a Andrew King LPSD pharyngeal device. Upon placement, they didn't see any complications. They were able to hear auscultation or lung sounds. There's no issues with bleeding or anything of that sort. And a capnography was used to confirm placement as well. They terminated efforts on scene because the patient was, they had a longer, they worked on the patient enough where they felt like there was no result of fuel. And after pronouncement, they did do an autopsy where they found a deep 5 centimeter laceration in the left piriform recess or the hypopharyngeal injury. The article just talks about how to keep in mind that aside from minor injury or tongue laceration, to also be aware of hypopharyngeal injury in king tube placement.
Yeah, so a lot of times people are concerned about like supraglottic airways, but it's not just supraglottic airways that people are, this can happen with regular endotracheal intubation. You have to be a little bit gentle, and sometimes if you do anything too forcefully, it can cause trauma.
Yeah, and I looked over this article as well. And I think it is important to remember that this is also a case study. And so this case study should probably never change our practice, so, it's an interesting finding, but really case studies are out there just to set up for case series, which then would set up for, like further study. But as far as like, changing anything, probably not a good idea. It's an N of 1.
I mean, I appreciate the article just because it's not that it's going to change your management or anything like that, but I think it just brings you back to the point that when you're trying to intubate somebody, whether you're using an LMA or a King tube or even an endotracheal tube, whether you're a paramedic, whether you're a resident, whether you're a physician, you always have to keep in mind that you can't just necessarily try to put the tube either through the cords or in the position that it needs to be to ventilate appropriately. You have to do it correctly. And I find myself, time and time again, when whether it's with paramedics or residents, that they're trying to, you can clearly see the cords and they're trying to just like badge it through the cord, and you have to tell them like, listen, you have to turn it to the right, you have to turn it to the left, you have to do it appropriately, whether the patient's paralyzed or not. And then maybe this is a chance where you can use a bougie to at least get yourself in and then walk your way through with a cord, because with the endotracheal tube, because you're having difficulty in trying to push the tube in the correct position just to try to get it in through the cord. So I think it's a good topic to discuss always.
Yeah, I find that a bunch of people are, they talk about bigger aspirations, things like that, by trying to push the tube too much. And that's also, it's a fine balance between putting in a large tube, because it's better flow and things like that versus the smaller tube. And you kind of have to, we estimate it when we see someone, a lot of people say, oh, it's a 5 or an 8, but you have to think about it. And like we utilize the Bronx as well. Not all Bronx will fit through certain size tubes. So if you think that the person's going to need like some sort of procedure down the line, they can always change it later on. Like your job is to kind of establish the airway, stabilize the patient, and then they can figure everything out afterwards. You want to do one more, or you want to just call it a day for today? Yeah, we can call it a day for today. So that concludes Journal Club for today. Our next Journal Club is going to be actually at the Jewish Home for Rehabilitation and Nursing in Freehold. That'll be on December 2nd. So, happy Thanksgiving.